Hi, welcome to this webinar about COVID readiness. My name is Nicola Dunbar from the Aged Care Quality and Safety Commission, and I'm going to be facilitating today. I'd like to begin by acknowledging the traditional owners of the lands on which we all meet across Australia today and pay my respects to elders past, present and emerging. And I extend that respect to Aboriginal and Torres Strait Islander people who are with us today. Thank you for joining us today for the webinar about being ready for a COVID outbreak. Our aim with this webinar is to revisit some of the foundation steps you can take to be ready for an outbreak and also discuss the changing context of COVID in 2021. Today, with the webinar, we have a number of speakers. We have Janet Anderson, the Aged Care Quality and Safety Commissioner, Melanie Rose, our Chief Clinical Advisor, Patrick Reid, who is the CEO at IRT, and also Anthony Speed, our Executive Director of Quality Assessment and Monitoring at the Commission. So we'll start. I'm going to hand over to Janet first to introduce the key issues for the webinar.
Thanks, Nicola, and hello, everyone. Thank you for joining us today. This webinar is very timely. There are significant lockdowns in place in New South Wales, Victoria, the ACT, and the Delta strain is proving to be particularly challenging to contain because of its higher transmissibility. We know all of that. The good news is that the COVID-19 vaccination is highly effective in preventing severe disease and death, including against the Delta variant. And further, we also know that high vaccination coverage will limit and reduce spread of the virus and help prevent new variants from emerging. So, internationally, the evidence is overwhelming that vaccination of as many people as possible offers a vital layer of protection for everyone. And we actually don't need to look overseas for that evidence. Compared with the outbreaks in residential aged care services in the Greater Melbourne area last year in 2020, we're now seeing firsthand the protective value of vaccination in reducing the risk of vaccinated aged care residents catching and transmitting the COVID-19 virus and becoming seriously ill with it. Since the current COVID-19 outbreak and series of lockdowns began in New South Wales in late June, 54 residential services in New South Wales have experienced outbreaks among consumers and staff. 26 of those outbreaks are currently active and the balance have been resolved. Of the active sites, the majority have had a single member of staff who has tested positive, and the majority have also had 0 residents with COVID-19 to date. And we already know the high levels of vaccination among residents in residential aged care services across the country. There are a small handful of services, certainly less than 5, where there have been 7 or more residents who've tested positive, and they have tended to be in services where there has been a lower level of vaccination generally among residents. Now, each of the outbreak sites is characterised by its own set of characteristics, and that is indeed what we saw in Victoria last year. So, as essential as the vaccine is, we must all understand that vaccination does not promise perfect total protection against the virus, because, of course, there is no 100% guaranteed protection strategy against COVID-19, and certainly not for residential aged care services where you have staff coming and going at the beginning and end of shifts. So what does that mean for providers of aged care? It underscores how essential it is for each of you as a provider to make sure that you have in place the foundations for effective infection prevention and control, and that you are also ready to swing into action without hesitation if your staff or residents are exposed to or test positive for COVID-19. So in short, and the ground we're going to cover tonight to remind you of your obligations is that approved providers have an ongoing responsibility to, firstly, monitor what's happening in relation to local and regional community transmission of COVID. Secondly, assure yourselves through self-assessment and drilling that you are taking all possible and necessary steps to prevent an outbreak in your service or services. And thirdly, maintain your readiness to respond quickly and effectively if an outbreak occurs. So the topics we're covering today in this webinar include the factors you need to consider when it comes to being COVID ready, as well as actions you can and probably should take to mitigate the risk of an outbreak. Last year, the Commission released a report that we compiled on lessons learned by approved providers who had experienced an outbreak in their residential service in Victoria. And in that report, we included the sobering observation offered by one chief executive who said, "We were prepared for a big storm, but we were hit by a tsunami." So in this webinar, what we'd like to do is to talk through some of the steps that you can and should be prepared to take so that you are ready for the big storm and reduce the risk of it turning into a tsunami. You do not have to be swamped by an outbreak. You can be more confident of a good outcome through great preparation and good strategy well executed. So the insights and experiences from our panelists this evening will equip you with a kind of knowledge that's invaluable not only in reducing the risk of an outbreak, but also, should you experience one, lessening its impact and helping you to keep your residents safe and healthy. Thanks, Nicola.
Thanks, Janet. I've just had a question about whether or not the webinar is being recorded, and yes, it is, and it will be available on our website in a few days after the webinar. So one of the things, Janet, that was there in what you were saying about the changing context, so what's different between now and 2020. Melanie, I'm going to come to you first to talk a bit more about this. So can you tell us a bit more about how the environment has changed for aged care in the last 12 months?
Yeah, and the obvious and amazing game changer has been immunisation. And, you know, the experience from overseas has absolutely borne that out, as it is starting to in our own experience now, where there are outbreaks and the great majority of residents and increasingly the great majority of staff are vaccinated. But I just want to dwell a little bit more on that impact, how really it's changed the stakes in terms of really protecting very frail and vulnerable people from their disease progressing to requiring hospitalisation and progressing to death, which we unfortunately have experienced when we weren't vaccinated in alarming and catastrophic and terribly sad numbers. So the outbreak impact has been very different in services where a large percentage of residents are vaccinated, and you know, I think that that should be used to encourage people to continue to be vaccinated if they continue to be hesitant. But really, it allows a little bit of a different conversation to have with your residents, that where before it was just such a disaster and instilled such fear and concern, that part of the picture is that instead of a really reasonable chance of it being a potential death sentence for some of your residents, it's now quite a small chance. So that really needs to be borne in mind. Another big change, of course, is the Delta variant, and not only is it more transmissible, it's more unpredictable, and where people have been seen to contract the disease really unexpectedly, where their contact with a person transmitting it to them has been either very transient or even unknown. Caution around this problem has led to large numbers of staff continuing to be furloughed in an outbreak, and in New South Wales Public Health Units taking a very understandably cautious approach to this. This approach may change as the risks become clearer with the Delta variant and in our newly vaccinated state, particularly where, for example, vaccinated people are caring for vaccinated people, and the risks there must be much lower. But other variants will inevitably occur, as alluded to by Janet, while ever there is a high number of people being infected with COVID, and internationally this is absolutely still the case. There is a chance, in fact probably an inevitability, that other variants will emerge as the more opportunity a virus has to replicate, the more opportunity it has to mutate to a variant that's advantageous to the virus. People who get mild disease, so I'm now talking about residents who are vaccinated who are very likely to have mild or even asymptomatic disease. It's still worth remembering that even mild disease in people who are very, very frail can tip the balance where somebody, for example, ceases to be able to eat. They're just not quite well enough to get their hydration and nutritional needs in, or they're very susceptible to getting other problems, so almost secondary problems. So there still needs to be careful monitoring of people, obviously. But where there are large numbers of staff furloughed, we have been seeing more recently more difficulty in replacing them. So there just does seem to be, in many areas, a lower availability of surge staff. So this does require clear planning and interactions at a local level to determine the situation should you be affected, where and how many of replacement staff will be available to you. The other big game changer potentially, and I hope it is a game changer, we've certainly seen some good examples of it, is the IPC leads being present. So where they are genuinely utilised for their skills, are respected and have a clear role in COVID planning and in COVID outbreak management, where this is occurring, it makes a massive difference. So that's where they're genuinely supported to take on a really well-informed IPC and PPE training, planning, monitoring, auditing, and of course where they become, and they should become, a key person on the ground as soon as an outbreak occurs. It would be very worthwhile planning for how they can continue to add value if they happen to be one of the furloughed staff. So it's also good to ensure that some of these IPC leads who are quite young and quite enthusiastic actually have the appropriate authority to act and to be listened to and engaged with. Another new thing is the new testing processes, particularly the rapid antigen testing, or RAT, which has shown to be very useful in some situations, and it's had a high acceptability to both staff and residents when it's used as surveillance in a pilot. It's important to note that it's not going to replace PCR testing, which is the gold standard. It's really useful as a screening tool, and it's important to know that it has different implications in different contexts, and that there are significant numbers of both false positives and false negatives. There are different products, and they're at the moment quite costly. So changes will continue to occur as new information and new community situations with vaccinations and hotspot information, all of those are going to continue to look different, and we all need to be ready for these, to adapt in our personal lives, but also where you're managing residential care services, that you need to be able to understand the information as it affects you and adapt really, really quickly.
Thanks, Melanie. Just following on from that then, given that rapidly changing environment, what are some of the issues that providers need to think about to ensure that they can continue to provide the best possible care, given it's not just, everybody's going to need to be furloughed or everybody's going to be sick, or it's kind of a mixed environment, and that in some ways may make it more challenging. So what are some of the things that providers and services need to think about in that kind of environment?
Sure. Well, there's a risk that there'll be too much reliance placed on the protective nature of vaccination. It's really important. Changed. and that the key goals of protecting the residents from the virus entering the service and protecting them from transmitting it within the service, and also protecting the staff from contracting the virus in the course of their work. And really the only way to do that reliably is to have very, very robust and well overseen processes for managing the reduction and hopefully prevention of transmission. It's really important still to know your residents, to know what the needs, goals, vulnerabilities and preferences are for each individual. Decisions relating to care in an outbreak will really consider many factors. Some of those will be your decisions and some of them will be reliant on the options and indeed the orders given by external parties, mainly the public health units in relation to orders, but also your own layout, your own where you place your vaccinated people currently. I mean, hopefully everyone will be vaccinated soon, but where you place them in relation to the small number of residents that continue to be unvaccinated, how you're going to protect those people who are going to continue to be at significant risk if they catch COVID. So how you're going to protect those in an outbreak setting, you'll need to really have an eye on who they are and where they are and why they might be at risk. You need to know your own risks at any point in time, obviously, including such issues as occupancy, density of living, where you've got shared rooms, local community transmissions and local community vaccination rates. To avoid large numbers of staff being cohorted, being furloughed, the better you can cohort them, the better you can still look at them and have them, if possible, working in circumscribed areas or zones only with a small group of other staff rather than mixing different shifts, different staff members, etc. And you need to be able to show that you've done that so that decisions about who has to be isolated or furloughed can be made. And something that we have continued to see, and I know people are aware of it, is planning for the big three impacts, what I call the big three impacts of a COVID outbreak. So even if you don't have a very large outbreak, even if it's contained and short-lived, we know, and it happens amazingly quickly, we know that there are three declines that residents, whether or not they have COVID, whether or not they're in hospital or they remain in your home, that they are subject to as a result of being isolated. And that's psychosocial decline, where people become depressed, lonely, frightened, bored, and fairly anxious. There's the physical decondition, where people who are stuck in their rooms and have less activity lose their muscle strength, often permanently, and that consequently has implications for reduced independent functioning, frailty, falls, and the third one is nutritional, where people eating in their own rooms have many reasons to lose their appetite, and where monitoring of intake and support processes no longer occur. So assisted feeding may be sporadic and not enough time is able to be allocated. All of those three things occur still, and they all impact profoundly on the status and the quality of life of residents. And it is really important that COVID outbreak planning addresses these proactively so that as far as possible they're prevented rather than waiting to realise they've happened in a fortnight, because they will happen. That's all I want to say, Nicola. Thanks.
Thanks, Melanie. That's really useful. I'm going to now turn to Patrick Reid, who is the CEO of IRT. Now, for those of you who don't know, IRT was founded as Illawarra Retirement Trust in 1969 and now has 6,000 people living in over 40 communities across New South Wales, the ACT and Queensland, and over 2,500 people received IRT services at home. Patrick, thanks for joining us for this webinar. It's really great to have you here to be able to share your experience of the work you've done at IRT in terms of being ready for COVID. Can you tell us a bit about those preparedness activities that you've been undertaking? Now you're on mute, Patrick. I'm sorry.
Yeah, no, I'm
there we go.
Hovering over the button, didn't push it. Thank you for having me. I think, first of all, to all my colleagues out there working so hard, thank you for what you do. Yeah, look, I suppose the main thing that we considered during the original COVID outbreak, which seems like a lifetime ago now, was looking at all the lessons learnt from the various outbreaks that we'd seen overseas. Obviously, there was a number in the US, UK and other places before it did start to spike here in Australia. And I think, as Janet pointed out, was looking at those experiences and getting ready for it. So we started very early looking at our outbreak management plan. Obviously, we have them for flus, rhinovirus and other things, but making sure we had hardened that target for COVID itself. So within that, working through the outbreak management plan, we're on version 29, I think, at the moment, about to release version 30 after some learnings from an outbreak or an infected staff member we had at Kirrawee in New South Wales. So, that's a lot of iterations, 30 iterations of a plan, which is iteratively getting better, you would hope. But what we also did was speak to our other providers. I think it's critical that you don't get isolated as a provider. You do have resources around you in terms of other providers. So we did start very early talking to the other 44 services in our region. We're in the Illawarra Shoalhaven primarily, but talking to other providers around the place to see how they were placed. And what we saw was, again, I think as yourself and Melanie and Janet have mentioned, different levels of ability and capability because of your size, your staffing, etc., and everything else you'd seen. So those conversations began very early, and I think we also include the LHD, our local health district, which is our hospital management system here, and they were very open to the idea of coming together as a group and trying to improve all of our circumstance around preparedness for COVID. And I think that was probably, I would suggest, a best practice outcome for the local region. So between ourselves, we started convening a weekly meeting where all the providers were invited, all the IPC leads, everybody was invited to come along and have those discussions. And from that, we iterated out all of our IMPs together. And in many cases, we shared them for critical assessment by each other, but also too from the LHD. So they actually freed up some of their resourcing. Their own infection control specialists actually came to all sites. And within, an area like this, that's a pretty big job, but that's now within New South Wales, at least. I can't speak for other states. We're now seeing other LHDs have done that as well. So having people come out to site, assess where you're at, make sure that you have got your processes and protocols at least up to their standard to work through it. From that, we also operate a 3 lines of defence model here at IRT. So those of you who are familiar with it, the first one is about your own business management and making sure that you are reviewing the risks and obviously putting the right management systems around it, the right people. And again, I think Melanie spoke about clear roles and making sure, particularly within an outbreak scenario and a management and governance scenario, that you're very clear on who's got what role during either preparing for it or during an outbreak. And that was very key. And also too, if you are handing off, it's normally 14 to 15 days at least during an outbreak. If you are handing off because of fatigue, etc., that there is very clear lines of who is then in control in those roles. So within the 3 lines, I think implementing risk and risk frameworks and management was very important. The second part is once you've done that, you've got your RMP, you've got everything in place, is to test it. And again, I think Janet said, test your plans, make sure they're ready. And I think it was an old Prussian general, Moltke, who said, no battle plan survives first contact with the enemy. And that was the view that we took, that no matter how well we had our plan in place, unless we tested it, scenario planned it out and challenged it, it probably wouldn't survive contact with COVID or any other major infection within the community. So that scenario planning was important. And then running our staff through it. So doffing and donning, where are your locations of your things, clean areas, hot areas, all those sorts of things, logistics, catering, laundry, etc., were all tested to make sure they were ready. So within that, developing that risk management framework and then testing it. And then the third line of defence really was having an external revision of that. And as I said, that was between our colleagues, reviewing our own IMP and checking on us and seeing where there were others. We shared them amongst each other to do, I guess, a gap analysis between all of ourselves. The second part then was the LHD providing some infection control and other advice to us. And then the third, obviously, was having other processes going on where we could actually validate our own internal processes and test them. So we actually we have an internal audit function here. Our internal auditor and some of her colleagues went out and tested the plan, went out and actually put people through their paces to see how they go in terms of an outbreak. So from that, we had a scenario planning session with all the providers, and we invited the Commission, and we're grateful that the Commission provided support for that through Kirsty. We also had some people from the Commonwealth, Jacob from the Department of Health, come along as well, because it's important to realise there will be a number of external stakeholders that will converge to assist during an outbreak. So we did that scenario planning to test pretty much what would happen in the first days or preparing for that OMP to make sure it's right. And then we followed up with a second scenario plan where we tested the first 24 hours. And everybody should have their first 24 hours checklist to run through to make sure that you've got everything on the ground that you require. So within that sort of scenario planning made it, I guess, clear to people where they were prepared or at least had things in place, or there may be gaps and what they needed to follow through. And so from that, we got a pretty good feel for where we're at with our OMP and also to our preparedness. And we're a large organisation, so we have a lot of sites. They're all very different. And again, I think Janet said you need to take account for each and every site is going to be individual and how it may or may not respond. All your safe zones, all those sorts of things will change. So making sure you have those plans for each site and they're all bespoke, which is a lot of work, but it's absolutely critical that that gets done and the staff fully comprehend it. So quite regularly, we will obviously do the reviews. As I said, we're on about we'll be coming to version 30 of our OMP pretty soon, and making sure all the staff are fully aware of what their role is in an outbreak. I'll probably pause there in case you have any questions, and then I'll go into our actual real experience when the battle plan actually got tested.
So Patrick, actually, if we do dive into that, that would be useful.
Mm-hmm.
So
yep.
how did it go when the battle plan got pulled out and had to get put into action?
Yeah, so we've established that outbreaks are like babies. They never come at midday on a Tuesday. They come at midnight on a Friday. So that was the experience for us. We were notified by the PHU that a staff member had tested positive to an external infection event, and that we were then obviously under our OMP protocol. So that was initiated at 12:05 a.m. And from that, we rolled straight into our 24-hour checklist, our first 24 hours checklist. And we're relatively lucky insofar as at that time of night, you can lock things down probably far more easily than if it's in the middle of the day with staff coming and going, next of kin, or those partners in care who are allowed in at the moment coming through, et cetera, et cetera. So there was some benefit to it being late at night, but not much. So within that, rolling through the first 24 hours was critical to make sure that we were, getting everything in place as quickly as possible. From there, probably the biggest issue that popped up immediately, and I think Melanie mentioned this, was the furloughing of staff. And one of the lessons, and I think somebody asked me before, what were you surprised by, that probably wasn't fully accounted for in your iterations of the OMP, was the extent of furloughing because of Delta. Now, the infectious rate of this means that those that have, close contact, yes, of course, they're going to be furloughed. But because of the risk assessment by the PHU at the time, waving at somebody across a car park almost became a furlough event. So that meant that a whole lot of staff were furloughed far beyond what we may have expected. And that does have severe impacts, obviously, on your workforce. But what we had done, again, using that 3 lines of defence model, was we looked at A and B teams and also to the cohorting of our staff. So making sure that they were sticking to a single building. There's 3 care buildings on that site and RV as well. And trying to make sure that we were cohorting staff so they were on the same shifts, they were on the same floor if possible, and not moving too often between buildings unless it was absolutely necessary. So those sorts of things make your workforce planning quite difficult, particularly at the moment where workforce shortages are hitting all of us. But that was an important aspect in terms of minimising the number of staff who were furloughed. In saying that, it was still quite large. So the number of staff that you lose during that first period is quite high. But then things start to swing into action. So obviously we were trying to staff across a weekend. We made sure that we had sufficient RNs and staff on site, of course, our IPC leads, and then splitting them out because we had 3 floors that were affected, making sure that we weren't going to cross over any of those staff across the next 14 or 15 days at a minimum. So there's a huge amount of work that your workforce planners have to do around that. And I'll come back to workforce in just a moment. I think within that, the key for us in the first 24 hours really was around triage, obviously looking at what we did there. Communication's the key as well. So obviously with residents, first and foremost, they're the ones who are going to be directly impacted by a lockdown. Then staff, of course, and next of kin, and then, of course, externals. So I think what we learned from Victoria and from other outbreaks was you can't over-communicate in this sort of scenario. And we went very much into twice daily, letting people know what was going on, and actually physically ringing each person who was affected as a resident, ringing their next of kin with an update around their health status by qualified staff. And that was probably one of the things that we did straight away to make sure that everybody had that level of comfort. I think, again, Melanie mentioned comfort around what you're doing, even with vaccinations, etc., that people knew that we were in control and that their loved one was being looked after. Obviously, we have an outbreak management team that was both on the ground and those that back them up offline and or off-site and online. And then we also have our own critical incident management team, which is formed of our executive and a number of others. So there's a number of management teams that we're working through to make sure that we had all the resources where they should be, and that we were, again, dynamic in our approach. And that team met the next morning, first thing, and then every morning, or if not twice a day, throughout the rest of the outbreak until it was closed off by the PHU. The other thing, too, is management of information. So making sure that you do have methods, because you will have external people coming in, whether it be surge workforce, it could be the IPC leads from the Commonwealth, or people from your local PHU and local health district coming in to assist. So making sure you have a really clear and concise information management process so they can get up to speed very quickly. And I think Janet mentioned this about residents' needs, wants, wishes and care, making sure that's all very clear. So they're not having to shuffle backwards and forth with paper or do anything else. They're fully briefed on each and every resident that you have. So that was important as well. I think too, the other thing that surprised us, I think because also too was a co-located site, was the logistics around swabbing, particularly when you're doing surveillance swabbing to minimise the risk of transfer of infection. And probably the thing that stood out most for us wasn't so much the swabbing itself, because that external agency that did that. It was the time it took to get the swabs back, because this was also in the middle of a major outbreak within Sydney. So time went from 12 hours for the first few swabs and was then blowing out to 99 to over 100 hours to get a result back. And again, when you're furloughing staff and waiting on a swab to get them back into the roster, or you're waiting on one particular resident to be cleared to make sure that they are healthy and don't have COVID, that's a stressful period for everybody because you're chasing through on those issues. So something just to be aware of as you do go through that process. I think the other thing for us, and we were very clear, and Melanie did mention about the residents and the 3 big factors that they do suffer from. One was their mental well-being and obviously connecting them back to family, making sure that they were connected, making sure they had things to do because they are confined to their room. And then also too, making sure that decomposition issue or that deconditioning issue was dealt with as soon as we could get an exercise physiologist or somebody else onto the floors. And we were lucky enough to find one for each floor to go and do some exercises, strength and conditioning work, etc., with residents to try and keep them going. I think the other thing that isn't mentioned, of course, we were lucky enough we didn't have a resident infected. It was only the one staff member across a couple of shifts, no other infections on site. But your residents will still continue to deteriorate if they were already being palliated. And how you work through with families in the most effective way to get them to say goodbye to their loved one if they are going to pass. And we had a number of people, unfortunately, who did pass during this period, not because of COVID, it was their time, they were palliating at the time. Is to make sure that you give space and dignity to that process as well, which can be difficult when you're really under the pump. But making sure you have thought about how those processes will roll out. And also too, often we were acting as counsellors to their family to let them know it was safe for them to come in. We would train them up on the PPE, etc., so they could spend time with their loved one as they passed. and say goodbye. So they're things that, again, they're in the OMP, but the practical experience was slightly different in a live outbreak. The other thing to consider is your environment. Obviously, they're all different, and our expectations did change as we got better advice. So what we have seen from version 1 to version 28 or 29 is that practice is evolving based on the risk profile of COVID, the transmissibility of Delta, and our understanding of how things are working better around PPE, around other processes, clinical and so on. So what we did find is that some of what we thought was best practice had morphed a little bit, and we were able to change that up as we went. And so being open to that input and that advice from those external people does place you in a far better position as you move through. And then, of course, we'll take those learnings away. The other thing was catering and laundry. So making sure, again, that you have processes for all of that, because the bulk amount of, obviously waste materials from PPE, laundry and how you're going to deal with it, clean and dirty or infected potentially, and then catering in terms of, no crockery, cutlery, it's all got to be disposable, etc. And making sure that your residents, I think as Janet pointed out, or it might have been Melanie, sorry, was around food and making sure that they are eating and staying well hydrated. So we did things like we supplemented with milkshakes and ice creams, trying to get them back to make sure they were having Ensure milkshakes, those sorts of things to keep both their protein and their energy levels up. And we had a few issues early on around blood glucose levels, etc., because we identified that was probably what was happening here. Their willpower to eat was declining because of lockdown. So those sorts of things are very important to keep a really close eye on. And again, the geriatric flying squad that we had, our own RNs and IPC leads, and our own staff, the ACE workers working with us were phenomenal in terms of identifying those sorts of issues along the way. Probably the main issue I think everybody is probably concerned about is workforce. And so for us, it really was around communication early and often with staff and being honest with them about what's going on, but also reassuring them. I think we had a lot of people quite nervous about coming to a potentially infected site and making sure they understood that actually with the PPE, the donning and doffing, the protocols that we have, there was nowhere safer really in Sydney at that point in time than where they were going to work because of all these scenarios and the effort that we put in around minimising any spread of the disease. And again, I said the other thing about cohorting was making sure you had, the right cohorting processes in place, because it does become critical around making sure you don't lose a staff member if they're working in a dirty area, and then you move them into a clean area. You can't use them back in the facility. Those sorts of things, and then really just working through training, making sure people looked after as well. It's not just the residents' well-being; it's the staff well-being. 14 days, we had people who moved in to that particular building for 14 days and did long shifts, 12-hour shifts to make sure that they were looking after residents and doing their very best. Phenomenal effort by people. You need to look after them and making sure they're okay. And it wasn't just the building that was locked down. It was the other buildings as well, because they were concerned for their colleagues and each other, making sure that you've got a bit of care and attention to them as well along the way. So we did a whole lot of things, but also too simple things like bringing coffee trucks in, etc., because they couldn't go out. Our cafe was shut; it was in the building. So being mindful of looking after people. And I'll finish probably on surge workforce. I think we were fortunate. We had a whole lot of shifts that were unfilled, obviously because of the furloughing of staff. We did receive some surge support, which is fantastic. But to note, it didn't cover all the shifts, and we did struggle towards the back end. But then as the surge dropped away because of other outbreaks and other facilities that were more critical than ours, then we did actually start getting our furloughed staff back, because we could work out, the swabbing, surveillance swabbing, plus isolation, etc. The PHU felt confident enough that we could actually rotate them back into the roster. So we have done our lessons learnt. The document actually came out today, thanks to Linda Hall and Charlize and Nia and my team. We have a lessons learnt document that's about 20 pages long. That will inform the next iteration of our OMP. And what we probably will do is form it up into something that we can distribute to our colleagues as well. And we'll make that available to whoever wants to get it. But it's something that we'll work through. Obviously, we've got some internal stuff that would bore people senseless, so we'll take that out. But the real lessons learnt, we can actually then provide to people. Just to help them, again, that thinking, as I said, that 3 lines of defence, have your processes, understand them, challenge them, and they get somebody else to get their eyes on it and tell you whether they think it's going to work or not in practicality. They're probably the things where we've landed today. So again, just thanks to our colleagues who have assisted us with that along the way. Margot Mains at LHD, Mark Sewell and the guys at Warrigal, and all of our colleagues here in the Illawarra. My team, Nia, Linda, Charlize, they've all been phenomenal.
Fantastic. Thank you, Patrick. And it's just so good to hear from you in terms of your direct experience about outbreaks, how you've thought about it, how you've prepared for it, and then how you managed it when one actually happened. So really good. And I'm sure there'll be lots of people who'll be interested in your lessons learned. I'm going to bring Anthony into the conversation now to talk to us a bit more about the Commission's regulatory approach. And Anthony, Melanie talked a bit about the changes between 2020 and 2021. Can you tell us a bit about, because you were very closely involved with the outbreaks in Melbourne last year, and can you share with us some of the things that we've learnt, what are some of the changes, what might be the differences in terms of responses, and perhaps some of the lessons that maybe should have been learnt and haven't been learnt from what you're seeing now?
Thank you, Nicola. The Commission is observing that a successful response to the prevention and management of an outbreak of COVID in residential care continues to be characterised by that preparedness and scenario planning and that strong and decisive leadership that previous speakers have spoken to. We see that the preparation and continuous review of your outbreak management plan at the service level is a really critical success factor. And that success is maximised where that outbreak management planning provides clear reporting lines, it provides defined roles that are understood by all staff on the site, and that includes your contract staff who come on for various service delivery aspects. The difference that on-site leadership makes at the service level, particularly in the first 24 hours, as Patrick referenced, following case confirmation, is absolutely fundamental, and that continues to be the most significant success factor, I think, in 2021. As the Commissioner mentioned earlier, we undertook the lessons learned exercise following those Victorian events, and that project report is on our website and continues to remain, I think, a valuable guidance material for the sector in 2021. Some of the lessons that we learned last year that are reflected in that report note the importance of having those really effective relationships with your local health service, be that the local health district or your state health department, particularly when it comes to having protocols in place and observing state protocols around clinical need and hospital transfers if that's required. So those relationships continue to be important in this current circumstances. Also, others have spoken about the importance of resident wellbeing, and Dr. Roth gave us some information about that. Really, really amazing examples that we saw last year around innovation in continuity of care, around supporting or maintaining resident weight and preventing deconditioning. That continues to be important in the outbreaks that we're seeing this year, and we detail some information around that in our report. Others also have spoken about the critical importance of continuous screening, and we're seeing in 2021 the absolute importance of maintaining those regular observations of consumers on site to ensure that they remain asymptomatic, to ensure that their well-being is not adversely affected by the restrictions that are in place on a site. And we also know that the importance of continuing engagement with your workforce around training in prevention control practices, around training around established zones and effective donning and doffing arrangements, for example, and the implementation of infection control spotters continues to be a critical factor in 2021. And of course, we know that early communication with consumers and families is important for transparency, but it's also important to maintain communication with your furloughed staff, and that's important to support their early return to work when it's clear for them to do so. I come back to the importance of leadership and governance. It's really important. We've learned, and we see again this year, the importance of that visible, strong on-site presence of leadership. Not just the clinical expertise and the infection control expertise that is now a requirement, but importantly also that role clarity for the staff that I mentioned. For example, establishing dedicated leads around catering or communication is really important to manage a situation. We also know that contingency planning for the future is important. So don't assume that an outbreak will be over in 14 days rather. It can last a lot longer than that, and you must think about contingency planning for a longer period of an active case. Others have spoken about workforce planning and absolutely fundamental to success. We know that a large number of staff can be furloughed as close contacts when there's an active case, and in those circumstances we see that surge staff have to be quickly located, they have to be quickly trained and oriented to a site. Every site is different, and they must understand the consumer profile of the service, and their orientation must include that awareness. But importantly, you must not assume as well that all surge staff will have an effective awareness of infection control procedures relevant to your service. So there must be ongoing awareness and training around infection control procedures. We also know that sourcing those staff is difficult, and in Victoria last year, we heard of examples where agency staff arrived that had no experience in aged care. So you must plan for those sorts of contingencies and think through scenarios such as those. As Dr. Rife mentioned, I think in 2021 the biggest game changer here is the vaccination. We are seeing the downstream impact of increasing vaccination rates on the active cases, and as of mid-August, there were I think it was around 67% of aged care workforce had received a first dose of COVID vaccine, and I think it was about 46% have had their second dose. That was in mid-August. Those figures are increasing on a daily basis, and that is fundamental to be aware of, informing and supporting staff to access those vaccines. And of course, on the 17th of September, National Cabinet has determined that will be mandatory. And I'd point to the resources and support available through the Department of Health and PHNs and others to support achieving that full vaccination rate. I think the other game changer that's been mentioned, and I agree with it, is the implementation of the IPC leads. So since February this year, there's the requirement for an IPC lead to be on site for all residential aged care services, and we're seeing the flow through of that increased expertise in the current circumstances. I think also there's obviously an increased awareness amongst the community in general about effective screening and infection control, and we must however remain vigilant about that awareness, and we must remain vigilant about that ongoing education necessary to prevent and minimise transmission. In this latest round of outbreaks in 2021, we have seen that there are unfortunately many providers that are unprepared for the number of additional staff that are required to provide continuity of care and services in an outbreak. And we've seen that additional staff resources for lifestyle services, for example, and communications with families remains a critical factor for success. We've also seen that where there's a delayed response by an approved provider in compiling and releasing a list of staff who worked at a particular service during a period of possible transmission, that delay can get in the way of effective contact tracing, and that's an important thing to consider when considering risk for consumers and service. So to have that visibility of who has been on site and who has worked on site during a recent period is absolutely critical. We've also seen several instances where an approved provider has been unable to rapidly supply a workforce roster for a period of, for example, 7 days, which has also limited the ability for a rapid response to the additional workforce support requirements that are often necessary. We're continuing to observe some services who have underestimated or been unprepared for the additional management and administrative resources that are required in an active outbreak. And in some cases, indeed, we've seen services where the on-site management team has been completely furloughed, which can significantly impair the response capability at that service. So again, it's that scenario planning, it's that coming back to an effective outbreak management plan to ensure that you are planning for what may or may not occur. We've also seen services that are effectively responding to an active outbreak on their site through their rapid implementation of their outbreak management plan. That there is a clear understanding of that plan, of the roles, and there is a willingness and an ability to swiftly adapt that outbreak plan as circumstances unfold. I think it's fair to say that most outbreaks are fundamentally different, but they also have many, many similarities. So I think in conclusion, we learned in 2020 that approved providers cannot over-prepare enough for an outbreak, and that this remains true this time in 2021.
Okay. Thanks, Anthony. That's really useful. And one final question as we kind of head towards 6 o'clock. The changing environment and changing outbreaks, has that had an impact in terms of the Commission's changing regulatory approach as well?
No, not at all. We've stepped up our regulatory approach through increasing our monitoring activities at this time. We're involved in outbreak management meetings wherever there's an active case, and we collaborate with our Australian and state government colleagues in public health units and local health districts to monitor cases. We've also recommenced our infection control visit program. We have visited over 50 services in New South Wales in the last few weeks. We will continue to do that. We are conducting rapid phone assessment contact where we have epidemiological modelling that shows that there is a particular risk in an environment. And last week we did a phone assessment contact program in the Bathurst area in response to some of that modelling. And we've also continued to undertake our assessment contact program. Since the end of June, we've contacted 872 residential aged care services in New South Wales alone to understand and assess preparedness for an outbreak, and we will continue to do that. And we will also continue to assess evidence and consider risk to consumers, and where necessary and required, we will issue regulatory action, and we have issued 6 notices to agree in the period since June in relation to COVID outbreak management.
Thanks, Anthony. We've just got a couple of minutes now before we finish, and I want to just ask a question of each of the speakers. I'm sorry, my sound is a little bit dodgy, so I apologise if I'm coming across a little bit dodgy as I'm speaking. That's a bit better. Thank you, Renan. A number of you have talked about the importance of leadership, and I wouldn't mind in the couple of minutes we have just before we finish, if we can just touch specifically on that. You've all emphasised the importance of it, coming at it from different perspectives. So I might start with Melanie in terms of, particularly thinking about it from a clinical perspective about leadership and the importance of that in being prepared.
Yes, so thank you, because clearly any clinical risks, either as a consequence of COVID or pre-existing clinical risks, need to still be monitored and overseen and responded to. And that is particularly difficult when key personnel are not able to be on site for furlough reasons, where key personnel are not on site for other reasons, it's a little bit harder to understand. But where there are a large number of staff working who are unfamiliar with the processes, unfamiliar with the residents, unfamiliar even with the layout and how to access such things as the medication cupboard and fresh linen, ongoing leadership is really, really important. And I think that it's really worthwhile planning for how your key leaders can still do these things from their own home if that's where they are. Now, there are lots of ways to do that, and we've seen lots of inventive ways to do that, but just try and work out what works for you with remote access to systems, with telephone or FaceTime participation in handover meetings, for monitoring the clinical condition of people from off-site and making contact with where the on-site processes are insufficient for those residents.
Okay, thank you. Patrick, your thoughts about leadership, particularly from your role as the CEO at IRT, I think is particularly interesting.
Look, I think leaders come at all levels. So a lot of it, as I said before, was around making sure people have very clear roles and responsibilities. You know, my care manager, Carly, Linda Hall, Yanti, Matilda, all these people and Mia in our team, they all had their specific roles and they fulfilled them, you know, magnificently. I think making sure they're clear on it, making sure they've got support as well. So we did have our CMT, our Critical Incident Management team, which was there to back them up and make sure we cleared any blockages for them that were off-site. And then, as Melanie just pointed out, making sure that you had people who could step in virtually if required to take pressure off that team on the ground, because they were there for 12-hour shifts across 14 days, you know, rotating in and out on the same location. So I think leadership is key around understanding the role and responsibility, but also to making sure you've got the right supports. And again, being ready, running through the scenarios, making sure you know what to do when it does happen. And making sure you're ready for that. So, you know, again, thanks to everybody who's out there working so hard.
Thanks, Patrick. And Anthony.
Thanks, Nicola. Look, I also add leadership can also be important in supporting your staff. We've seen examples where staff are working 12-hour shifts. So look, some leaders are working a lot longer than that. Whilst it's important in emergency situations to respond in that way, it's also important to ensure that you're supporting your staff's resilience to continue. Because as I said, the outbreak may not be over in 14 days. It may be a lot longer than that. So leadership through preparing for the long haul is important as well as the short-term response.
Okay, thank you. And finally, I'll hand to Janet now for her reflections about leadership and also closing comments for the webinar. Thanks, Janet.
Thanks, Nicola. Let me respond with a question to the audience. How are you feeling right now? Are you galvanized, or are you daunted, or are you somewhere in between? Frankly, as long as you're interested and engaged, we've achieved our purpose this evening. There's a lot in our operating environment which remains uncertain. And in times of uncertainty, the best advice is always to control the things we can. So there is a lot that's within your control as approved providers of residential aged care. There are layers of prevention and protection readily available to you that you've heard about over the last hour. You need to reduce the risk of COVID entering your service. You need to get ready and remain ready to respond rapidly and confidently to an outbreak. You must test and retest your readiness and fix any gaps that are exposed 29 times and counting for Patrick. And stay aware of what's happening in the local and regional community in relation to COVID and continue to review your plans in light of the changing circumstances in your operating environment. And what Patrick said, and he used the word dynamic in our approach. I commend that thing to you. Dynamism is the key. Be flexible, be agile, be responsive to what you have in front of us, and make sure you're ready. As Nicola said at the outset, this webinar has been recorded and we'll be posting it on our website in coming days. And please also check out the resources we have on the Commission website in relation to outbreak management planning They're available. They've been available for some time. We look to update them as we go, and they are a very useful source to you among other resources which are available. Thanks to all of you for staying the journey, and I hope you found this to be a valuable reflection and reminder of what's most important in preparing for and responding to an outbreak of COVID-19 in residential aged care. Thank you.